Well, hello, and on behalf of the Royal Society of Edinburgh, welcome to our Health and Wellbeing panel today. My name is Alan Gow, and I'm a Professor of Psychology at Heriot-Watt University in Edinburgh, and I'll be chairing the session today. Just before we get started, as you may be aware, throughout the month of August, the RSE are hosting a whole programme of events as part of their Curious series. These are online events offering insight from leading experts and themes including health and well-being, like today's, innovation and invention, and our planet. Now, some of those events are called Tea and Talk events, hosted daily at 3 o'clock, a format inspired by the coffee house debates of the Scottish Enlightenment. Some spaces are still available for the final week of those events. They're kept very small to facilitate that intimate experience of debate and discussion. Today's event is different. Today is a panel discussion. So we're going to be hearing from two speakers, and I'll introduce them in a moment. And we have almost 150 people joining us, and you'll get a chance to ask questions of the speakers. And at any point, you'll see you can fill in questions for our speakers in the Q&A section. So what are we going to be talking about today? Well, we're going to be talking about health and well-being, but more specifically, mental health. The World Health Organization states that there's no health without mental health. And while it's always important to look after ourselves, how do we care for our mental health during a global pandemic like the one we're currently living through? What about the most vulnerable people in society? And are there any silver linings to being in lockdown? So we're going to be hearing from two speakers. They'll each speak for about 10 or 15 minutes. After we've heard from both speakers, we'll then open the second part of the session, where I will be taking some of the questions that you've been posting for our speakers, and we'll try and address as many of those as possible. So please do use that Q&A tab throughout the session as questions come up for our speakers. So I will introduce our very first speaker today, which is Dr. Stella Chan. Now, Stella is a Chancellor's Fellow and Reader in Clinical Psychology at the University of Edinburgh, and as well as being clinically active as an honorary clinical psychologist within the local NHS child and adolescent mental health services. Stella does a lot of communication about research, a lot of engagement activities, and is also a member of the Wellcome Trust's Cognitive Neuroscience and Mental Health Expert Group. I see Stella has joined us now, and Stella is going to get us started. So Stella, over to you.
Hi, hello everyone. So I go back to that one. My name is Stella Chan. I'm an academic clinical psychologist. I'm based at the University of Edinburgh in beautiful Scotland. And I always use this photo rather than a professional portrait because I really like the Highland cow. You can see at the back and always make me feel more confident and calmer and happier. So hopefully my talk will give you some ideas about how to make you feel soothed and calmer despite all the stress we are surrounded by at the moment. So 10-15 minutes is a very small amount of time. So just want to ask you a quick question. Do you want to be an adolescent in general? Not necessarily now, but in general, would you like to be an adolescent? So give people a minute or two to respond to this. Well, we're waiting for the result, which is coming up soon. Yes, so actually only 9% of people say, yes, you want to be an adolescent again. 83% say no, and 7% not sure. So thank you very much, Katrina. This is very cool to have the instant result like this. I've asked this question many times whenever I give public talks. And your results is actually even more extreme than this is the result I got in the past. So the overall trend is that the majority of people actually don't want to be adolescent again. Only very small percentage of people actually want to be teenager again. And in fact, you are quite wise in choosing no, because adolescence is indeed a developmental stage with heightened vulnerability. So perhaps at this point, I should kind of say that Stephen, the second speaker, and I have agreed that I will focus on adolescents and young people, and then he will talk more about adults and general population. So here, I want to share with you some of the facts and findings about young people's mental health, which is actually quite striking and quite sad. So this is the MQ Manifesto for young people. So MQ is one of the biggest charity organizations in the UK that look after mental health. So here you can see that from their results, 3 children in every classroom have a diagnosable mental health condition, and 75%, which means there's 3 out of 4 people of those who had mental health difficulty reported that they developed symptoms before the age of 18. So mental health problems are actually very much a young people's problem, as much as, although it affects us across the lifespan, but it often starts very early in life. And it's not only that it's very common, but also we know that almost half of the young people believe that if they have a mental health diagnosis, they may never get better. They may be treated differently, and they will feel embarrassed about that. So there's a great deal of stigma around mental health that is really unhelpful, because it fundamentally stops people seeking help, and that make a bad problem even worse than they are. So this is recognized as a global health challenge. So I don't know where you are, but from our colleagues in the RSE, I know that people joining us today come from all over the world. So wherever you are, I just wanted to say that mental health problem actually affect people across the globe. So it's not necessarily the problem of specific countries, actually affect everyone. And World Health Organization did recognize that, especially for the teenagers age group, depression is the #1 cause of illness and disability. If you just focus on depression itself, it affects 300 million people worldwide. And it's not an easy thing to treat, and it can be very complicated, and some of the symptoms don't go away, or they may come back. So it's actually quite a complex disorder. In the US, for example, look at young people alone, 11% of young people reported having at least 1 episode of depression, and 1/4 of them were classified as severe depression with suicidal tendency. Here in the UK, 80,000 children, young people suffer from severe depression. So only severe depression, not to count the milder and more moderate type of depression. And another important thing to know, that we do know that children who are in care, sometimes they may be reported having behavioral or emotional problems, but they could actually be sign of depression or other mental health problems, but manifest more like a behavioral problem. But actually what is underlying is the difficulties with the mood. And we also know that the number of young people with depression nearly doubled across 20 years, from 1980s to 2000. Now, based on another longitudinal study, which is kind of study that run on for many years in the Netherlands, 16% of them have experienced major depressive episode by the age of 19. The average age of onset to average age when depression start emerging is around 14 years old. We also know there's a small subset of young people who have more than 1 disorder, so they seem to be particularly at risk, and that illness seems to come back more often. Now, most of the data, of course, come from the high-income country, but there are now emerging data from Asia and lower middle-income countries as well, that similar figures are reported worldwide. And interestingly, we also know from other people's research that there's low agreement between parental and adolescent self-reported symptoms. So if you ask the parents what they think the children are having, what symptoms they have, is actually it does not agree very well with the young people's own report. Okay, so this is a very is a relatively old research study in 1998, but I keep using that in my talk because the data today is very much the same. What is so striking here, if you look at the data between 11 years old to 21 years old, this is the percentage of people who have depression. You can see that actually from age 13 onwards, women have a much higher chance of getting depression than men. And this gender gap never close across the lifespan. So women are constantly at higher risk. This is really striking, I think. Another thing is how to conceptualize risk and resilience. Resilience is such a hot topic now. Everyone talk about resilience. So the one way to conceptualize it, to imagine us like a jar, so it can hold certain amount of contents in it. So if you think about risk factors, you can think about genetic risk factors, so your genetic predisposition, but also environmental factors like stress, lifestyle. So all put together is constantly pushing up in the jar. So we can experience depressive symptoms if there are too many in the jar, so keep pushing up and pushing our limit. But at the same time, if we want to look after ourselves, one way to think about that is that we can try to take out some of these risk factors, try to modify them, but can also try to expand the jar. So make us, have more capacity to cope. So these are about developing resilience factors. So the important message here is to think about both risk factors and resilience factors. And this is something we can discuss more in the Q&A section. And in one of our recent studies, we look into many factors that may be associated with adolescent depression. And you can see that these are all the different areas we look at, and these are all the factors that we know are associated with adolescent depression. So when I say associated, it's difficult to tell that whether they are risk factors or they are just a consequence of depressive mood. But nonetheless, we know that these tend to happen when someone is depressed. So such as cognitive style, negative thinking style, rumination, you're thinking round and round in your head, neuroticism, which is a personality risk factor. That is a personality that I have quite high neuroticism myself. It doesn't mean that you're ill or you're not very good. It just means that you're more prone to having worries and anxiety. Stress, external shame, another big factor, which means that the way we think about other people think of us. So if we really worry about how other people think of us and constantly worry that people may think badly of us, then that is also a risk factor. Now, all these are very intuitive, isn't it? So the next question, I don't have time to talk about what can we do about this. But what I want to move on now, I know a lot of people joined here today want to think about the current situation of COVID. So this is my second question to you is, reflecting on the first question, do you want to be an adolescent in general now? I want to ask you, do you want to be an adolescent now, particularly in COVID? Oh, this is really exciting, waiting for results. Yeah, so people even more reluctant to be teenager. And again, we all have seen in the news all the saga of exam results and school opening, reopening, closing, and all that sort of thing. So just want to spend a moment to think about why does COVID affect young people? In what way? Of course, it affects all of us, but why young people are particularly affected? This is a rapid review, literature review by Maria and her colleagues at the University of Bath. They have reviewed over 80 papers in the past. Now, only one paper, only one study, research study was done in a disease containment context. So there's not a lot of results out there because COVID is quite a unique situation. But if you look at this one research study, we do know that young people who were in isolation because of disease containment context, they're more likely to have developed grief or adjustment difficulties, acute stress, or post-traumatic stress disorder. Now, looking in general, when it's not COVID or pandemic, we do know that there is substantial amounts of research evidence to show a very strong link between loneliness and both current symptom depression and future symptoms of depression. So it's predictive for future problems. Now, more interestingly, is the duration of the loneliness rather than the intensity of loneliness. So it's how long you have been lonely rather than how intense the loneliness is. That seems to be the bigger predictor for depression. Now, this is a point that we can come back to Q&A and discuss it more, because I think it really has a strong relevance to how we can better support young people. Another study I want to share with you is by Generation Scotland. This is the team led by Professor David Potiers here at the University of Edinburgh. So Generation Scotland is a long ongoing longitudinal study in Scotland. Have a lot of people taking part in their research, but more recently they have launched a COVID-specific survey. They have got more than 18,000 survey volunteers who are 18 years old or older, so for adults, in the acute month between April and May. So they found that nearly half of people worry about post-COVID employment, economic recovery, also have increase in feelings of loneliness, isolation, more depression, anxiety reported, and poorer sleep quality. And in particular, the younger age group within this generation, this population, 18 to 29 years old, seems to be particularly affected. Now, then they launched another survey that are specific to teenagers. So they they were working in partnership with schools in the school network across Scotland, coordinated by from colleagues at the University of Glasgow. So the SHINE network. So they have invited the research team has invited young people from 283 schools across very wide geographical area, and they got more than 5,000 responses. This is one of the biggest study in teenagers in COVID time in the UK. Now, so some of the interesting results at first, it found that nearly 3 in 4 young people are going to bed later and report poorer sleep quality. Only 13% of them reported that the sleep have got better, but 50% of them say that their sleep have gone worse. Now, if you look at loneliness, again, they come back to the same concept. Before lockdown and after lockdown, you can see the general shifting towards feeling more lonely. So more people reported that they feel more lonely after the lockdown of COVID. And in terms of worry and stress, seems to be these are the kind of main categories in terms of the education, exams, and worry about the future. And over 50% of them find that it's quite or very difficult to adjust to homeschooling. And 41% feel that they're stressed some of the time about COVID. And 16% most of the time, and 7% of them actually feel constantly worried about that. But the silver lining, as Alan has prompted us to reflect on, is that most of the young people, although feeling stressed and worried, they do find that there are support available to them through their family, the school. They feel that there's always someone there if they need them, which is really good to know. Not every young person have support, but majority of them feel supported in Scotland. So that's something good to know. So towards the end, I just wanted to step out from the teenager mental health to think about actually old people mental health in particular, because we know that COVID affects old people very much, especially those who are in care home, and being shielding, and that loneliness is just unspeakable. So in one of my research projects called Project Soothe, and you can put it in Google, called projectsoothe.com, or see us on Twitter, Project Soothe, and you'll find out all about the study there. So I won't go into detail here, but the essence of the project is that we collect images from people that make them feel soothed, and we share these images on our website. So that we have done so far. But more recently, since COVID, we've been working in partnership with Cockney Health, and they have an app called Cockney Care. So this is an app that was designed for carers of people with dementia. So we're now designing a new app feature to be put in Cockney Care app to help to give people the opportunity to browse some of these soothing images. They can use emoji to indicate their feelings and their mood, and they can then see whether their mood changed from before to after looking at the images. They can personalize their preferences. They can share it with their friends. So we're now at the final stage of testing the app feature now. It should be ready for launch very soon in the next couple of weeks. So watch this space and get back to me if you want more information, or look up website of Cogni Health. So these are some of the images we're collected from Project Soothe. So I thought that before I switch to the time to Stephen, I just share some of these nice images with you. So I look forward to discussing more with you in the Q&A time. Thank you.
Well, thank you, Stella, for that overview. Some really important figures and data and plenty to discuss. We've already got some excellent questions coming into the Q&A. So if anything that Stella has said, talked about, has fired your interest and imagination, please do start filling those in. We'll get through as many of those as we can. Before we do that, of course, we have our second speaker. And as Stella alluded to, we're going to be hearing from Professor Stephen Laurie. Now, Stephen is a chair of psychiatry and neuroimaging and head of the division of psychiatry. He previously studied medicine at Aberdeen before training in psychiatry at the Royal Edinburgh Hospital. He's an honorary consultant psychiatrist and works with NHS Lothian, based both in Edinburgh and across southeast Scotland. So, Stephen, please take us through your talk.
Thank you very much, Alan, and thank you to Stella, and thank you for everyone who's wired in to this event. I'm going to talk for about 10 or 12 minutes about the psychiatric aspects of the lockdown and the COVID-19 pandemic. And I'm going to do that really without slides, but try and keep a relatively simple structure that will hopefully be easy to follow. So I'm going to talk about it from two perspectives. One, the population health perspective, or the public mental health perspective, you could say, about how these recent events have affected everybody. And then secondly, I'm going to talk about some specific psychiatric potential complications of having the COVID-19 virus, and in particular severe infections that might take you into hospital. So I guess it's worth clarifying right from the beginning. I'm going to talk about, when I say psychiatric, I mean diagnosable mental illnesses according to the various diagnostic criteria that there are. And those are conditions that once defined, once people meet those criteria, they are likely to benefit from some kind of treatment, whatever that treatment might be. So I think Stella has already drawn attention to very nicely the sorts of problems that are affecting us all during the past few months, have affected us all since the lockdown in April and May, and perhaps have only slightly eased with the easing of lockdown in June and July. And those affect the whole population. They may affect the young people in particular, as Stella has drawn attention to, but we all have, of necessity, been less physically active, less socially active. Many people have not been working and may have suffered financial problems as a result. We are less able to meet friends and have been less able to meet friends and family, socialize, and do all the things that, to a large extent, make our lives worth living, or at least add value and enjoyment to our lives. And if you take those away from most people's existences, then it's not surprising that you see an increase in the levels of anxiety and depression and stress and loneliness and boredom across the population as a whole. And there's quite a lot of surveys that have shown that. I'm just going to mention one in particular because it was, to my mind, relatively well done and has been well publicized. You may have seen mention of it in the BBC News website or in several newspapers last week. It was done by the Office of National Statistics based in London. And the particular value of that survey was that they had access to a population of about 3,500 people that they studied with the same questionnaires a year ago. So they had a fairly good way of establishing the effect of the past few months in these people who they've surveyed, before and after the pandemic and the lockdown and the slight easing of that. And in essence, what they showed was that there has roughly been a doubling in the levels of anxiety and depression in the population as a whole, as indexed in these 3,500 representative people of residents of the UK in general. So that the figures really went from very high anyway to concerningly high, and it is now reckoned that, roughly speaking, 20% of the population will endorse levels of depression that may indicate that they have a depressive illness that may benefit from treatment, and a similar percentage have levels of anxiety that may be sufficiently severe to meet diagnostic criteria and benefit from treatment. Now, I put several mays in there because this is a population screen done by survey. I mean, the survey was, I think, done with the PHQ, the Patient Health Questionnaire that many of you might have filled in if you go and see your GP as a routine health screening measure. But just because one has a certain number of symptoms, and even of a certain duration, 2 weeks in the case of diagnosing depression, it doesn't necessarily mean that all those who screened positive on this questionnaire, in this survey, around about 20%, would actually have a depressive illness. To have a diagnosable depressive illness, people would also need to be significantly distressed or disabled by the depression. And usually, clinically, a psychiatrist like myself would at least bear in mind contextual factors like what is going on in people's lives, what sort of chronic stresses they may be under. And in some people, a depressive illness would not be the correct diagnosis. One might be more inclined to say it's a stress-related problem or an adjustment disorder, to use the language of the international classifications. Nonetheless, usually when one screens populations, it's more than, with these kind of instruments, it's more than 50% of those who screen positive who do have a diagnosable depressive illness. And it's very likely, therefore, that at the moment there are more than 10% of the population who have diagnosable levels of depression and 10% with anxiety. Some of those people will have both, and they may well benefit from treatment. Now, of course, from a population health perspective, one would want to be able to wish away all the concerns and problems associated with lockdown, but that, as we can see from governments around the world, is easier said than done. And it's likely that many of the factors that have triggered the depression, loneliness, boredom, inactivity, financial concerns, social problems, perhaps particularly in people who were disadvantaged before the lockdown, it's easier said than done to actually do much about that. And people may well therefore benefit from going to see their GP and getting signposted to various support services in the community. They may benefit from some forms of psychotherapy, and they may benefit from antidepressants. Even if they have ongoing stress, antidepressants may relieve some of their symptoms, like sleep impairment, for example, and that can have big effects in terms of people's general well-being. So the second thing I wanted to talk about is the more specific effects of having an infection with COVID-19. And obviously this is work in progress. We are still learning about the effects of this particularly nasty virus as time goes by, but it's becoming increasingly clear from a number of studies. And there was a recent review in the Lancet Psychiatry which brought all this evidence together. As far as we can tell, a lot of this evidence is based on previous experience with SARS-CoV-1, which affected large parts of the Southeast Asian population in 2002. And so this evidence may not necessarily apply to SARS-CoV-2, which is the other name for COVID-19, but it probably does. And what is clear is that people who have a severe enough infection to end up, for example, in intensive care, where there is a very significant mortality, as you might expect, have a very significantly increased rate of post-traumatic stress disorder some weeks or months after coming out of hospital. And it looks like the rates of post-traumatic stress disorder in those people are around about 30 to 40%. Now, some of those will ease with time, as one would expect. If one recovers from a life-threatening illness or condition and gets one's life back to normal, then a lot of people, perhaps over a year or two, would spontaneously recover from those kind of problems. But probably the majority of that 30 to 40%, probably around 20%, are in the position where they probably would benefit from some kind of treatment. Again, whether that's drug therapy or psychotherapy might depend on their preferences and what's available locally. But they might benefit in the sense that their illness might become less severe or for example, allow them to get back to work sooner rather than later. The other, there's a couple of I think, COVID-19 related psychiatric or mental health problems that I think are probably yet to fully declare themselves. One of these is, you will probably be aware, some people who have had the virus complain of ongoing problems with confusion or fatigue. And it's well recognized that a number of infectious illnesses, even the common cold and the flu, for example, can give rise in a minority of people to post-infectious fatigue states, which have been called chronic fatigue syndromes, or even in severe cases, myalgic encephalomyelitis in the past. And I think we can probably expect there to be an increase in the number of people with these kind of problems over the next few months. And then the other thing that I suspect is likely, but we haven't really fully seen yet, are partly this will be a reaction to the easing of lockdown and will apply across health services generally, in that people will, as life slowly but surely hopefully returns to normal, people will be able to perhaps deal with problems that they have not felt able to bother their GP or physician or psychiatrist with. And I think there's some indication in the Royal Edinburgh Hospital, for example, in the past month, we have had double the number of admissions to our hospital beds than we did at the same time last year. Now, we don't know enough to be able to say how related to COVID-19, the release of the lockdown, or other factors like ongoing financial concerns that might be, but it's certainly giving us cause for concern. And to end on a positive note rather than a slightly macabre one, I think I will point out that whilst there are many people who have suffered as a consequence of the lockdown and the pandemic and some infections, there are some people who have found that they have got more time for themselves, for exercise, for example, for their family, perhaps particularly those who are doing particularly busy or stressful jobs. And I think there are some potential mental health bonuses or assets, if you like, that may arise as a result of the academics, as a result of the pandemic. So, for example, we might be able to hold more events like this. There's no reason why people need to travel to meetings quite so often as they did in the past, and that might increase access to various people and also reduce the costs if people get more into the habit of interacting electronically like this. So I'll stop there and thank you for your attention.
Well, thank you, Stephen, for that overview as well, taking up from where Stella left off. So Stephen, if you would like to come back, and Stella, come back as well. We're now going to move into, you can't get away easily now. This is the bit where it gets really fun, because we've got a whole series of questions which I'm going to start distributing to each of you. Just before we start that, I will just answer one very easily. As chair, I get to take a simple one, and it was about slides, if they're going to be available. Do remember the whole event is being streamed on the RSE YouTube channel, being streamed live, but it will be available after today as well. So if you did see some things on the slides earlier that you didn't quite catch all of the details, then please do feel free to go back into the recording and look at those. As we go through the questions, please do keep adding more questions in. We don't want Stephen and Stella to get away too easily today. So we've got about 25 minutes to go through some questions. So I'm going to get started. So Stella, I'll come to you first. You mentioned in part of your talk about a doubling of some of the incidents. I think it was depression specifically in adolescents. Is that an increase in the incidents, or is it an increased level of diagnosis? Are we able to tell what's happening there?
I don't think we're able to tell, definitely. My hunch is that it's probably a bit of both. I think in recent years, particularly, there have been very successful awareness campaign, involving royalty, and it just have a lot more awareness. Politicians started talking about that. So I think increasing awareness does make people they're more aware of that, and they need to seek help. And that said, though, despite all this awareness campaign, stigma remain a very important issue that hinder people from seeking help. So I think it's really complex. I don't think we can comment on whether it is by really a genuine increase in incidence or just people kind of more seeking help. But I think the message, the bottom line is the same, is that if we have more reported cases, that would mean that the services need to increase to cope with that. And I think some of those very bad headlines people see on newspapers, such as like long waiting lists, and so it always kind of put the pressure on clinicians as though it's their fault. But actually it's not. It's about the capacity of services and the funding spent on that not matching up with the increase, no matter what is causing the increase.
Thanks. And I think that's a really interesting point, isn't it? The increased awareness, not necessarily that drives cases, but it might drive people to seek support. So Stephen, I'll bring you in on that as well. If you could speak to that from your own practice, because you work day to day in a clinical setting. Do you have a sense of that idea? Are we seeing increased incidence more generally, not just COVID specific, or is it that people are more able to come forward and identify these problems, do you think?
Yeah, I think it's probably both. I agree with Stella that one has to be very careful about how one interprets these kind of surveys. But I mean, I think the ONS study, the Office for National Statistics study I cited, was quite carefully done, and I don't think there's any doubt that there's been an increase in the level of depression symptoms reported over the past year or so, and that, as I alluded to, probably, can't say definitely at this stage, probably does translate into an increased incidence of depressive illness as such. I mean, there's no doubt, as Stella said, that depression seems to be more common in women. Partly, though, they are more likely to describe symptoms of anxiety and depression than men, and one has to bear those kind of differences in mind. But I think overall there is an increase in the numbers of people with depression, as well as the numbers of people who are willing to report it or discuss it, which is generally a good thing, that people are more open about these things.
And Stephen, just picking up on that survey you mentioned that came out in the last couple of weeks about the increasing reporting of symptoms of depression. Now, there was a lot of media reporting of that,
Yeah.
but a lot of the reporting talked about depression versus symptoms of depression. Would you be able to speak for a minute or two just about, what do we mean by the difference between those, and why would it be important for us to know the difference in a media sort of engagement sense?
I think it is important, and it's also difficult because as soon as one starts to get more specific about this thing, it becomes a bit technical and dull. But part of the problem with the word depression is we all get depressed at times, and that might be for minutes, hours, or days, and that is not what a depressive illness is like. A depressive illness lasts for at least 2 weeks, and is associated with impairment in everyday activities. And I think enough people in the population, probably 20%, will have an episode of depression during their lives that is that bad. But I think unless you've had it or known someone with it or tried to look after someone with it, it's very difficult to appreciate just how different that is to just everyday sadness. And in particular, fortunately rare, but very severe depressive illnesses, there's a significant mortality associated with them, because people, not just because people can kill themselves, but sometimes people stop looking after themselves, stop eating and drinking, and it's a very serious illness. It used to be called melancholia, which is arguably a better word for it, but I think the media reporting of this particular survey result was quite good in that they did talk about depression as though it were a diagnosis and depression the symptom, but partly these discussions are kind of hamstrung by the rather everyday nature of the word depression.
So, Stella, coming back to you were focusing obviously more on young people, adolescents, and young people. And one of the things you touched on was loneliness. It's quite interesting when you talked about the difference between the duration of loneliness, experiencing it for a long time, versus the depth of that experience. I wonder if you could tell us a wee bit more about that. What is it about the duration versus the intensity of loneliness that might be particularly important?
And that comes from a recent rapid literature review led by University of Bath. So that actually was a response to the COVID situation, because instantly. I think anyone who works with young people, the primary focus and concern was about school closure and the kind of social distancing and social isolation. I think it's a very interesting one. Is about the intensity and the duration. I'm just thinking that as a clinician, speaking as a clinician, you sometimes see people who have been lonely for a very long time. And sometimes you see people who have been made lonely, so to speak, because of the situation. Maybe they moved to a new school, maybe they moved to a new town. So in the beginning, they didn't know anyone. So I suppose that a short duration loneliness, even if it's very intense, it may not signal a longer term problem. Whereas if a long-term loneliness sometimes could be environmental, like now, which is very unique situation because it's kind of the environment factor. But often other people loneliness could also signal kind of difficulty in social relationships or geographical isolation. So I've seen people that they're perfectly sociable, but they just live in a place that they just couldn't have any social life without driving for miles and miles. And so particularly in some countries and some communities, I suppose. So I think what matter is that if the result is about the duration that matter, we need to think about the school reopening. So some of these things nowadays, thinking about young people taking turns, so to speak, to go to school, because you need to maintain social distance, so you can't all be there at the same time. That would be preferable than having kind of an even longer term time of not seeing your friends. Another thing to reflect on is that we talk a lot about social distancing, but are we actually talking about social distancing or physical distancing? Because social life nowadays can happen in a non-physical closeness sort of way. So like now we're connecting with more than 100 audiences around the world. And to be honest, for me, it's not the same as seeing their faces in a big tent or in a big lecture hall or, a community center. I do miss the connection with my audience, but at the same time, it gives us new opportunity, as you earlier on say about silver lining. It gives us new opportunity to connect with people who normally wouldn't probably be in Edinburgh to attend this event. So I'm thinking that one of the things that we do know is that COVID is COVID. And we can't just say, assume it's not here because it's here. So given, I think we need to make the best use of it and trying to have be more willing and be more daring to change. How can we capitalize on the opportunity to change the nature of social life? How can we maximize the quality of social life when we can't be physically together all the time?
Thank you for that. Coming back to you, Stephen, and I'm going to combine a couple of questions that came in about gender differences. So both Stella and you talked about gender differences in mental health, both presentation, diagnosis, and the question that we've got is about, why is it that women might be more likely to be diagnosed with a clinical level of depression? Is it just simply that they're more likely to seek help? And how do we square that with the fact that men's suicide rates seem to be so much higher than men? What's going on with those sort of what seem like inconsistent figures? Can you give us a bit of a sense of what's happening there?
Yeah, I think I can explain the apparent inconsistency, at least. Explaining the sex difference in depression that Stella drew attention to with her slide is a complex and ongoing research question. I mean, it's been known for a long time that women, generally speaking, are twice as likely to get depression or be diagnosed with depression. And that difference comes on in the mid-teens. It seems to coincide with, let's say, the demands that are made upon women in that phase of their life, and it eases slightly in their 50s. It seems in part related to biological factors associated with reproduction. For example, period problems, to put it that way, is associated with depression and anxiety. There's a clear risk of having a baby, much as most people are fortunate enough to have a very good time with a baby. About 10% of women will develop postnatal depression after pregnancy, but it's probably more related to structural factors in society in terms of less opportunities for women in a general sense, The women that do work tend to end up working and running the home, and so on and so forth. I think why men are more likely to commit suicide is well established, but it comes down to the fact that even though depression is twice as common in women, it's still pretty common in men. So there's about 10 to 12%, let's say, of men who will have a depressive illness at some point in their lives. And it seems this relatively simple explanation is that suicidal men choose physical methods of attempting suicide. So rather than take an overdose, as typically many young women might do with depression, they will attempt to shoot themselves or hang themselves or drown themselves. And those kind of physical methods of suicide are much, much more likely to succeed than taking an overdose, for example. So taking an overdose is very unlikely to result in a successful suicide attempt, whereas hanging, shooting, and those kind of methods that I'm drew attention to are unfortunately more likely to be successful. And that's why older men in particular with access to guns and the like are very serious concerns if one is looking after them clinically.
Thanks for that, Stephen. And as you say, it's a really, a tough story in the sense that, the successful methods, unfortunately, are the ones that the men are choosing in that context. Stella, coming back to children and adolescents, one of the questions that we've got is about, is it, or how might we help young people understand that what they're feeling just now might be a completely normal reaction to what is an unusual, we hear it a lot, unprecedented, stressful situation, so that we wouldn't necessarily label with a mental health diagnosis or issue. Would labeling in a period like this have a longer lasting effect, for example? So I wonder if you could maybe talk us a little bit about that.
I think this is a question that often come up because I go to school a lot and do a lot of school-based work, and with young people, parents and teachers also ask this question a lot. It's actually extremely difficult, even clinically, to make as a clinician, to make a sort of decision about, I often get asked, one question I often get asked is, am I technically depressed? So it's actually, there's no such thing as technically depressed. Of course, we have diagnostic manual. We can make some kind of clinician judgment, but by the end of the day, I think we need to also be mindful that it is about individual life. How bad is bad? How much is intolerable? These are very much a subjective experience. And also that technically, of course, we can do a questionnaire, we can say this is the level of severity, but at the same time, one of my master's students actually at the moment is looking at subclinical level of depression and how that perception of that by young people is going to affect young people. So one of the things that she identifies is that if you look at online forum, people talk about the depressive symptoms, young people, and you got some other people maybe judging other people and thinking they're faking the depression because they're not serious enough, or maybe describing other people as attention seeking. And I know that is the sort of thing that is quite concerning for suicide as well, for amongst young people, is how, as I alluded to it earlier in my talk, what we think other people think of us actually make a big difference to our well-being, particularly for young people, because we all remember what it's like to be young people, to be in school. It's very intimate, social relationship, very intense. So coming back a long way, coming back to your question about how do we know, is I think we need to accept that sometimes we just don't know, because the definition is somewhat arbitrary. However scientific we try to be, there's always something arbitrary there because it's a subjective feeling. The bottom line is that if people listening here, as a parent, as a teacher, as a young person, you want to ask yourself, are you feeling so sad that you can't cope? Or is life in a way that you can't cope? So not only about feeling, but like, can you cope with your schoolwork? Can you cope with the pressure? We occasionally have a bad day. A bad day is not a bad life. A bad week is not a bad life. But if you have many weeks, persistently feeling bad, then that may be a time to ask for help. If you're not sure, just ask for it. There's no harm asking for it. So I would say that definitely if you have someone you can confide to, just talk to them. There's not a problem. If it's great if you turn out you can cope better than you think, and that's great. And the more you talk about that, the more you normalize it for yourself. And what you may be surprised to hear is that other people will tell you, oh, I felt exactly the same. Then actually it does make you feel better, because it's a shared suffering. It actually does help.
To come in on that point, because it leads directly into another question that was posted as well. How can parents help their children, and where should they go for advice, both the parents and the young people? Is there a specific charity that you would recommend, or other clinical support that you think what's the right route? And I know there might not be one right route, but is there if there was one piece of advice you would give parents or young people, what would it be in this situation?
I think just checking with RSE, if it's possible, I think that it's possible for us to send some information to our audience later. Then I can actually send a couple of links of resources. So there's a lot of resources available now. But sometimes the danger is that, like, sometimes if you Google things, you ended up like just get yourself into panic. Sometimes I Google my symptoms, always end up saying that I have some serious illness, that I'm going to die, something like that. So just be mindful of that. But there are resources. But I would say the first point of contact would be if it is something that you immediately worry about yourself or other people's safety. If we talk about that level, I would go straight to a GP and get a referral to be seen properly. If it's sort of a bit unsure, just feeling a bit low and down, not quite sure where you are, you can start with some self-help materials. There are a lot out there, and I can send some link of resources. But if in doubt, I think speaking to GP and to talk to someone would be a good way forward.
Good, thanks for that. And speaking of resources, I know that Katrina from the RSE has posted a few links in the chat space for everyone to see. As we're aware, when we talk about mental health, for some people, these issues can be difficult, and they can set other worries and concerns off. So if anyone is worried or concerned, please do look at some of those resources. There's particularly a couple of links there about suicide and suicide prevention. Stephen, coming back to people who have been diagnosed with COVID and who have been in intensive care, we know that many people were seriously hospitalised, and some people continue to be. Do we know if the rates of psychiatric problems after hospitalisation in people who've been diagnosed with COVID and have been in intensive care are higher than for other physical illnesses that required intensive treatment? Or so is COVID related to something like that, or is just being in that intensive environment something that could be a trigger for a mental health issue?
Well, it's a good question. I don't think we know exactly the answer to that. It's certainly well recognised that going into intensive care, in a general sense, which is almost by definition a life-threatening condition, is associated with developing stress reactions or post-traumatic stress disorder weeks or months thereafter. And we are likely to see an epidemic of that. I wish I hadn't used that word, it's a bit sensational, but we're likely to see a dramatic increase in the number of cases of that in the next months and possibly even years. Mainly, I think, because of the number of people who seem to be suffering very severe respiratory distress as a result of the COVID-19 infection. I don't think, as far as I'm certainly not seeing any evidence, and my hunch is it's not a specific thing to COVID-19, it's more a specific thing to the severity of the respiratory distress that it can cause in many, but fortunately still a minority of those people who get it. I was wondering if I could deal with another question that I saw about trying to deal with the stress of that, because it seems to follow on quite neatly. Somebody said, would it be best to provide treatment for those who had the virus to try and prevent PTSD? Well, the problem with that is, yes, it's a nice idea in principle, and there are some guidelines out there. There's the Royal College of Physicians of Edinburgh, for example, posted only in the past week or so some guidelines from the traumatic stress clinic at Imperial College in London about how physicians, surgeons, and everyone looking after people in these kind of situations might approach these kind of issues. Obviously, the first thing you have to do is save someone's life, and it may not always be the right time. I mean, they may be exhausted, they may be delirious, to think about trying to treat anxiety or depression as a possible way of preventing post-traumatic stress. I think the key thing is probably to be aware of the risk, and to I guess open up communication channels so that people could report those symptoms or concerns if they are there. There's actually interesting, there's one of the very earliest Cochrane reviews of routine counselling to try and prevent post-traumatic stress disorder after traumatic life events found, rather counterintuitively, it did not help and actually seemed to increase the risk. So there is something to be said for the stiff British upper lip after all. And, you know, routine counselling is not the answer, I don't think. I think the answer is being aware of the possible issue and opening up communication if possible.
Thanks for that. And I'll let you come in a second, Stella. We've only got a few minutes left, so I want to try and squeeze a few questions in. So do you want to come on to Stephen's point quickly there first?
No, I want to actually respond to one of the questions about how to help young people. I think that is quite a good way to round it up a bit as well. So from a research point of view, I always want to kind of confess when we have a big audience that we actually don't know enough about depression or mental health problem. We always come out and, sounds like we're expert, but however much expertise we have is just based on limited research finding. So one of the things that I think we could do better, that come back slightly to the question about why there's more men dying of suicide, but yet more women depressed. Question like that could potentially be answered if we know more about the subtype of depression. So at the moment we talk about depression as though there's one thing, so we got talk about 300 million people worldwide have depression. They can't be the same. There must be some subtype. For anxiety, for example, we have done a lot better in knowing the subtype, and that's why the treatment can advance. And the same need to be done for depression. And there are work led by University of Edinburgh, for example, by Andrew McIntosh group, is trying to advance that kind of subtype of depression understanding. But how to help young people? Another thing that I want to say is that sometimes we give young people a lot of pressure, or ourselves a lot of pressure, feeling that as though it is entirely our responsibility to look after ourselves. Of course, we have responsibility, but as a society, we need to have the right kind of supportive environment for each other. So if you're in a very hostile environment, if you throw someone into a lion den, they can't really chill out, isn't it? So I think that thinking about compassion being really a big risk factor and big resilience factor at the moment, coming out from research finding, being able to be compassionate towards yourself and compassionate towards others with the view of building a compassionate society is something that I think that would very much help us through the COVID.
And Stella, just jumping off, you mentioned anxiety there, and one of the questions was about, in a strange, almost unexpected way, is the increase of people in general experiencing anxiety in the current period, is that potentially beneficial for people who've been experiencing anxiety more generally? Because does it help them see that actually this is something that might be things that other people experience, very, very briefly, because unfortunately we've not got a lot of time, but do you think that could be something that's possible, that there could be a benefit of that wider awareness?
I think yes, for awareness, yes. But in general, I'd rather people not be anxious.
Absolutely. And that was fantastically brief. And Stephen, I'm going to finish with one question just for you as we finish off. You mentioned about treatment in your talk, and you talked about medication or psychotherapy. Do we have any information yet about how successful those psychotherapy type via something that is like Zoom or online? Do you have any sense of that?
Yes, I think there's quite a good literature. So partly addressing Jackie's question about the situation in the Highlands, things like internet provision of CBT for depression and various other apps out there are pretty much almost as good as actually seeing someone face to face, at least for the initial stages. I mean, some people might need more than than internet CBT or an app, but they're definitely worth trying. If you can, try and get one that's evidence-based, supported by clinical trials, but you know, in low resource settings, or actually just about anywhere where there are routinely 6 to 12 month waiting lists for some kind of psychotherapy, those things are definitely worth a go.
Thanks for that again, Stephen. Nice brief one at the end. And we are absolutely bang on our end time. Unfortunately, we didn't get a chance to do all the questions, but as we would expect with a topic such as this, there's always going to be so much more interest than time. So just to finish off, I'd like to thank everybody who came along to listen, who posted questions, to our two panelists, Dr. Stella Chan and Professor Stephen Laurie, and of course to the RSE for hosting the event today and throughout August. Do remember there are still events in the final week as part of the Curious programme. There are tea and talks on menstrual health, on genetics, on alternative methods for tackling climate change, for example. So get onto the RSE's Curious website, sign up for those and take part. But for now, thank you very much, everyone, for taking part, and do take care of yourselves, as both Stephen and Stella have been suggesting. Thank you.